Call upon Professor Vishali Gupta from PGI Chandigarh to talk on immunomodulators and biologics. Can they change the course of non-infectious uveitis? Dr. Vishali Gupta, please.
Thank you very much, Dr. Biswas. Thank you very much, sir, for the very kind invitation for this instruction course. The topic that has given to me by Professor Biswas is immunomodulators and biologics. Can they change the course of non-infectious uveitis? Now, before we start talking about changing the course, the basic question, why immunomodulate? So corticosteroids, as we all understand, are the first drugs which we all use in non-infectious uveitis, but when we use them on long-term basis, there are lots of side effects. So we invariably shift to immunomodulatory therapy in the cases where you need more than 10 milligrams steroid per day beyond 3 months to control the inflammation. Patient is not able to tolerate steroid, resistant to steroid, or there is a severe site-threatening non-infectious uveitis that is expected to have poor outcome. So immunomodulatory therapy, we have two categories. One is the conventional, including methotrexate, MMF, azathioprine, which is generally the first line. And now we have got biologic response modifying drugs, which we commonly call biologics. They are generally added when the conventional drugs are not working, but now that we are getting more comfortable with them, they are becoming first-line therapy in diseases like JIA or Behçet's, which are very severe form of site-threatening uveitis. There is this whole lot of chemical response or mechanisms of uveitis, and when you think about it, there are lots of cycles are lots of chemokines which need to be targeted, and therefore many a times you may have to combine therapies because a single one may not work till the time we have reached a stage where we can give personalized therapy. Now, can they change the course of non-infectious uveitis is the question which is the topic of my talks. Well, the pro is yes, they can, because they help in reducing the recurrences. Now, why are you so scared of recurrences? Because every time there is a recurrence, there is a residual structural damage. You may feel that, well, patient came to you, you treated with steroids, and 4 weeks later you tapered off the steroids, patient was fine, but again comes back after 1 year and you give another dose of steroids. It might work in some diseases, but every attack will lead a structural change and some change in the integrity. The problem with these is that these drugs have their side effect of their own. So it is not that every form of uveitis you will put them on these drugs because you don't want recurrences at all. So how do you go? We come back to my favorite thing is categorizing the uveitis or phenotype. Look what type of uveitis you are seeing, because all the anterior or posterior or panuveitis are not same. Within that broad classification, you have very different diseases which have very different prognosis. So you may be dealing with some of the diseases like posterior uveitis. This is APM-PP, which we don't see much in India. But well, this is the classic image of Dr. Don Gass. So this is APM-PPE, or you may find mutes. And mutes somehow we have seen almost 3 cases following COVID vaccination now. So don't panic, because many of these are self-limiting. So it's not that you are seeing and you start the patient on immunosuppression. Just wait, for some time till you are investigating. And within 1-2 weeks, you may see the condition has started responding or resolving on its own without treatment. The second category of uveitis comes monophasic, but it is recurrent. And HLA-B27 is a very classic example of it, where acute attack comes with a bang, goes away with topical steroids. You don't even need oral steroids to treat that attack majority of the time. And you keep the patient on 1 drop, 2 drop steroids for some time. He will be off all the recurrences. So you don't really have to push biologics or immunosuppressants in this patient because these attacks do not really lead on to any long-term damage. Now we come to the third category, which is posterior arpan uveitis, and these are the conditions: VKH, sympathetic, Behçet's, and necrotizing scleritis. If you see, these are the conditions which are really going to be multiple episodes, recurrences, leaving lot of morbidity and maybe mortality in patients like Behçet's. So these are the diseases that would require a long-term immunosuppression and maybe biologics to begin with. The decision to treat individual patient and the choice of therapy always keep a list of risk-benefit ratio. What is the risk of the therapy versus what is the benefit of the therapy, and most of the times you will get answer. Now let's begin with one of the most difficult cases to treat is juvenile idiopathic arthritis. Now, sophisticated time-updated modeling of GI-associated chronic uveitis has shown that any inflammation in these children doubles the risk of visual impairment and triples the risk of blindness, which means you cannot afford I do see, sitting in where I am, patients carrying the prescription because the prescribing doctor was too scared of giving steroids, either topical or oral. So very typically they start, and then even before they see the response, they already tell them to taper it off. That is not what is going to work for JIA children. They are going to get blind out of that kind of protocol. Similarly, there is Behçet's. There is a beautiful site cohort study which says that active uveitis in Behçet's increase the risk of visual impairment 2.5 folds and blindness 2.7 folds. So here the risk of giving steroids, biologics, immunosuppressants is much less compared to the benefit of preventing blindness. Systemic immunosuppressive therapy, the lessons that we have learned so far, and by and large they have come from the beautiful trials done by John Campen's group, is immunosuppression reverses visual field loss, normalizes retinal damage that you may see on OCT, and complete suppression of inflammation halved the risk of choroidal neovascularization versus active uveitis, whereas minimally active uveitis was no different from active uveitis. MUST trial is something which actually gave us the confidence to treat. It had 7 years follow-up in uveitis patients, and it showed that if you give regional therapy with fluocinolone acetonide implant, it was associated with an 81% excess risk in the odds of blindness versus systemic therapy with steroids and immunosuppression. The answer is very simple. You are treating a patient of Behçet's or VKH who's going to have lots of extraocular manifestation. You cannot really treat it with Ozurdex implants and local, because in meetings you will see somebody showing you a beautiful picture. Lady came with exudative detachment, I injected Ozurdex, detachment went away, all good. But you don't know what happened to that patient 10 years down the line. Is that patient still seeing or not seeing? So don't get carried away too much by just treating local. Local is a good adjunct, but not a supplement to systemic treatment. And each relapse prior to re-injection or re-implantation, because you can't really fine-tune the timing of re-injection and there would always be delays in the real life, this causes cumulative damage, which has been defined as sawtooth decline. So evidence of effectiveness of immunosuppression has been very well documented in birdshot, multifocal choroiditis, late stage of VKH disease, and of course JIA uveitis. Side cohort study dealt with non-alkylating agents and alkylating agents. Alkylating we are not using anymore, but non-alkylating they do help. This is beyond. Very few further minutes I will take about the biologics, which mainly we are using anti-TNF, and a systemic review by expert panel of American Uveitis Society recommended infliximab or adalimumab as the first line therapy for Behçet's and second line for JIA. But by and large, even JIA, some of us, including the rheumatologist and pediatric rheumatologist, have moved on to biologics as first line with the addition of methotrexate. So using this regimen, over 80% of the patients could achieve inactive uveitis with successful corticosteroid sparing, and that's a big thing. You don't want a child stunting body growth, no bone growth on steroids, Can steroids be tapered early with biologics? That's the question which many people have asked, and we have two trials. One of the patients with active uveitis and one with suppressed uveitis. Both showed that more than 50% reduction in the relapse rate with adalimumab in the face of rapid oral corticosteroid therapy. So if you are scared of giving steroids in JIA or something, you are giving biologics in that scenario. By the time biologics are taking over, you can reduce steroids. So this is the kind of the thing. If you have seesaw kind of inflammations coming back, majority of these children will end up in a scenario like this. Syncamore is another multicenter double-masked clinical trial which randomized active JIA to receive methotrexate or in combination with adalimumab, and they found that treatment failure occurred in 60% if you give only methotrexate and 27% if you combine adalimumab. So it's worth taking the risk of giving. And can I take 2 more minutes? I don't know why I made such a long talk. I'm surprised. Well, if your colleagues in the other part of the world are seeing and reporting some etiologies, it may be you are missing out on them. For example, these are the patients with granulomatous uveitis. And we were thinking, are they JIA? Because we love calling JIA to all the patients with children, when they come with uveitis. Well, they were not TB, they were not sarcoid, they were not positive for JIA, but they were labeled as JIA. And this is the kind of the fluorescent diffuse leak. HLA-B5 was negative, no evidence of Behçet's. And when we started looking for NOD2 gene, which is an autoinflammatory Blau syndrome, these children, we have quite a few of them who are positive for that. So some of children with these kind of autoinflammatory diseases, you can see this is post-treatment with adalimumab. This is what you want to achieve, that anterior segment looks good, posterior segment looks good, no residual effect of the disease. That is something the early intervention with these drugs can do. So my last slide, do IMT and biologics influence the course of uveitis? Yes, they do, by reducing the recurrences, by reducing the complications, and not only that, by reducing the systemic complications also, because when you are treating them systemically, you are treating the extraocular disease as well. Thank you very much, sir, once again.
Thank you very much for the wonderful, elegant talk. We are now really moving more to the immunomodulators in general everywhere, and biologics has come up, and we are switching to biologics, many of the cases like JIA and Behçet's, which you have highlighted. So thank you very much.
Thank you.